Welcome to this training session on mass casualty incident response, covering scene zoning, field triage, treatment, and transport for frontline healthcare providers. My name is Dr. Nasser Hassan Abdalrady, emergency medicine consultant and educator, and I'll be walking you through this material today. Let's begin. Before we get into the clinical content, a quick note on format. This session is structured like a tabletop exercise, a discussion-based way of thinking through a mass casualty response. As you watch, treat it as a chance to test your own reasoning against a realistic scenario, not as a test of right or wrong answers. 4 ideas anchor this approach. It's discussion-based. There's no time pressure. We're testing plans rather than people, and any gap we find here is one we never have to discover during a real event. By the end of this session, you should be able to do 4 things. Describe the zoning concept and how casualties flow through a scene. Apply a rapid field triage method to sort patients by priority. Explain how treatment sectors are organized and resourced. And outline how transport is prioritized so that casualties are distributed safely across receiving hospitals. This lecture follows 5 modules, each built around a scenario inject followed by the key teaching points. Scenario briefing and notification. The zoning concept at the scene. Field triage. Treatment sector operations. And transport and hospital distribution. As you go through it, keep a few ground rules in mind. There are no wrong answers. Reason from your own scope of practice. And treat any disagreement with the material as a sign that it's worth discussing with your own team afterward. In a real mass casualty response, several roles work in parallel. The incident commander owns overall strategy and resource requests. The triage officer directs initial sorting at the scene. The treatment officer runs the treatment sectors. The transport officer matches casualties to receiving hospitals. The safety officer owns scene hazards and zone boundaries. And a staging or resource officer manages incoming personnel and equipment. As you watch, think about which of these roles maps closest to your own. The terminology in this session draws on established, widely used references. The World Health Organization's Emergency Medical Teams and Disaster Risk Management Guidance. The U.S. National Incident Management System and Incident Command Structure. The START and Jumpstart Triage Methodologies. And the American College of Emergency Physicians Disaster Medicine Resources. These are widely recognized starting points, but your own facility or national mass casualty plan should always take precedence over anything said here. Let's ground this in a scenario. It's 0740 hours. A public bus carrying 52 passengers has collided with a fuel tanker on a highway overpass at the edge of the city. Initial reports describe multiple casualties, a possible fire, and a partially blocked roadway. The weather is clear at 34 degrees Celsius, and your facility is the closest level 2 trauma-capable hospital, roughly 12 minutes away by road. The first responding ambulance crew has just arrived on scene and radios in a brief size-up. This scenario is fictional and used for training purposes only. A few things worth thinking through at this stage. What is your own facility's activation threshold for declaring a mass casualty incident? Who needs to be notified first and through what channel? What initial resources would you request from EMS dispatch based on a size-up like this? And how does a receiving hospital begin surge preparation while the scene is still active? Take a moment to consider how your own service would answer each of these. Once responders arrive, the scene itself needs to be organized into zones. The hot zone is the area of immediate hazard, fire, fuel, or structural collapse, and entry is restricted to trained rescue or hazmat personnel only. The warm zone is a buffer for extraction and decontamination between the hazard and the safe area with controlled access. And the cold zone is the safe area where most healthcare workers operate. This is where triage, treatment, transport, staging, and command all take place. Casualties flow from extraction through a casualty collection point into triage, then into treatment by category, and finally to transport. Here's what that looks like laid out on the ground. The hot and warm zones sit off to one side, closest to the hazard. Everything else lives inside the cold zone. Casualties move from the collection point into triage and from there into color-coded treatment sectors, red for immediate, yellow for delayed, and green for minor, before moving on to transport. Staging, the command post, and areas held for media and family are also part of the safe zone, kept separate from the clinical flow so they don't interfere with it. A few questions worth sitting with here. Where would you physically locate the casualty collection point for a scenario like this, and why there specifically? Who has the authority to control access into the hot and warm zones? How do you keep the cold zone from becoming congested with bystanders, media, or family members? And what is your plan for scene security and the surrounding traffic control? With the scene organized, the next challenge is sorting a large number of casualties quickly. Field triage exists to identify who needs a life-saving intervention right now. It takes seconds per patient, not a full assessment, and re-triage continues throughout the response as conditions change. Patients are sorted into 4 categories. Immediate, for life-threatening injury requiring intervention now. Delayed, for serious injury that can safely wait. Minor, for the walking wounded who need little more than self-care. And expectant, for those who are deceased or whose injuries are incompatible with survival given the resources available. The method referenced here is START for adults and Jump Start for children. Here is the START algorithm in full. First, can the patient walk? If yes, they are triaged green, minor. If no, check breathing. If they are not breathing and still are not after you reposition the airway, that is black, expectant. If they are breathing, check the respiratory rate. Under 10 or over 30 per minute is red, immediate. If the rate is normal, check perfusion. An absent radial pulse or a capillary refill over 2 seconds is also red. If perfusion is intact, check mental status. Inability to follow simple commands is red as well. Only a patient who can walk or who passes every one of these checks is triaged yellow delayed. This is simplified for teaching purposes. Always defer to your local protocol and the full START or Jump Start criteria. Let's apply that to 4 patients. Patient A is a 28-year-old female walking and crying with a minor laceration to the forearm. That's green. Patient B is a 45-year-old male unconscious with a respiratory rate of 34 and no radial pulse. That's red. Patient C is an 8-year-old child with a respiratory rate of 24, a capillary refill of 3 seconds, who follows commands after the airway is repositioned. Using the pediatric criteria, that capillary refill makes this a red as well. And patient D is a 60-year-old male who is of NAC and remains so even after the airway is repositioned. That's black. It's worth asking yourself, how would your answer change if your resources were already overwhelmed? Once triaged, casualties move into treatment. They move into color-coded treatment areas that match their category. Red, yellow, and green sectors are kept physically separate. Staffing and supplies are allocated by priority. Red sectors are resourced first, then yellow, while green is often largely self-sufficient. The interventions here are essential and time-limited only: airway management, hemorrhage control, splinting, not definitive care. And patients are retriaged continuously. Some improve and move down a category, others deteriorate and move up. A few questions to consider. With limited staff, how do you decide the staffing ratio between red and yellow sectors? Which interventions belong in the field treatment area, and which should wait for the hospital? How do you handle retriage as a patient's status changes while they're waiting? And what is your plan for tracking and documentation under high patient volume? The final piece is getting casualties safely to definitive care. The transport officer tracks every casualty leaving the scene and matches ambulances to triage priority. Red casualties are transported first wherever feasible, with the load spread across multiple receiving hospitals based on capacity and capability, not simply the nearest facility. Real-time communication with a regional coordination point prevents any single hospital from being overwhelmed. And essential information travels with every patient, their triage category, key findings, and the interventions already given. Worth thinking through. How does your region coordinate hospital capacity during a mass casualty incident? Bed counts, operating room availability, specialty services. What information should accompany each patient at the point of transport? How do you prevent over-triage from bottlenecking at the closest facility? And as a stress test, what is your surge plan if 15 red patients arrive at your emergency department within 20 minutes? In a real exercise, this is the point where the group would pause for a hot wash, a short, structured debrief held immediately afterward while the discussion is still fresh. As you finish this session, it's worth asking yourself the same 4 questions. What went well? What was genuinely challenging to decide? What would you change in your own local plan? And what follow-up training or resources does your team need? Let's bring it together. Zoning protects responders first and organizes casualty flow second. Triage is rapid and dynamic, a sorting decision, not a diagnosis. Treatment sectors match resources to priority, not to perfection. Transport prioritization prevents any single hospital from being overwhelmed, and rehearsing all of this before a real event is what makes it usable during one. This session draws on guidance from the World Health Organization's Emergency Medical Teams Initiative, the START and Jumpstart Triage Methodologies, the U.S. FEMA National Incident Management System and Hospital Incident Command System, the American College of Emergency Physicians, and the International Federation of Red Cross and Red Crescent Societies. All of these are worth reviewing in full as part of your own preparation. Thank you for watching. I hope this session gives you and your team a clearer, shared picture of how zoning, triage, treatment, and transport fit together during a mass casualty incident. Questions and follow-up discussion are always welcome. This has been Dr. Nasser Hassan Abdalrady, emergency medicine consultant and educator.